Good afternoon, friends, and a warm welcome to this afternoon webinar on vitamin D and pre-diabetes. Now, today is a special day. It's the 14th of August. Tomorrow we celebrate our Independence Day. Independence from what? From many things. Of course, independence from colonialism, independence from being dependent upon other countries, and independence from ill health, independence from disease and disability as well. This is what we would like to celebrate as a country, as a nation. When we speak about independence from ill health, independence from disease and disability, we have to know that we can't do it alone. So, if you have a concept of dependence, that is maybe the lowest level of existence that can happen. I am dependent upon someone else for my care. I am dependent upon someone else to take care of me or to decide for me. Above that would be independence. But then, even above that, would be a higher level of living, a higher level of existence, and that is known as interdependence. Interdependence means we are all dependent upon each other. All of us logged in this webinar, for example, to achieve the best of health, the best of happiness for all our fellow citizens. Let's take interdependence to the field of medicine. When we speak of vitamin D, for example, that's a vitamin, it's a fat soluble vitamin. If we speak of pre-diabetes, that is a glycemic condition. It's a syndrome where there is dysglycemia. That's carbohydrate metabolism. How do these interact with each other? This is what interdependence means in metabolic medicine and in internal medicine. When we speak of interdependence, then we would like to learn about that as well. So let's welcome both our guests today, people who have brought Indian endocrinology, Indian medicine to world-class levels. A warm welcome to Dr. Saptarshi Bhattacharya, who is a consultant endocrinologist at the Apollo Indraprasth Hospitals in New Delhi. Warm welcome, sir.
Thank you, sir.
Dr. Saptarshi is also Secretary of the Delhi Endocrine Society. He is past Secretary of the South Asian Federation of Endocrine Societies, and he serves on the Executive Committee of the Endocrine Society of India.
Thank you.
We also welcome our senior diabetologist, Dr. Jothydev. Dr. Jothydev Kesavadev is from Trivandrum, and someone who has single-handedly, warm welcome, sir.
Thank you very much.
When Mrs. Jothydev is around, then we remain muted. So, because of Mrs. Jothydev, actually, Dr. Jothydev has been able to bring Trivandrum to the map of Kerala, Kerala to the map of India, and he has been able to place India on the international map. So, when you speak about diabetes, when you speak about diabetes technology, cutting edge aspects of diabetes, then it is Dr. Jothydev who leads the talk. Dr. Saptarshi and Dr. Jothydev both are interested in history. So, a few nuggets. Even before vitamin D was discovered, that was in 1903, Niels Finsen from Denmark won the Nobel Prize in Physiology and Medicine. He was able to show that concentrated light, sunlight, is able to treat lupus vulgaris, which is the older term for tuberculosis. So, 1903, vitamin D won a Nobel Prize for itself without even being known that it was vitamin D. In 1927, Adolf Windhorst from Germany created cholecalciferol, and he won the Nobel Prize for that, the Nobel Prize for Chemistry in 1928. In 1927, one of the companies from Germany had been able to produce cholecalciferol. So in 3 years from now, we'll be celebrating 100 years of cholecalciferol as a pharmaceutical drug. This is about the fat-soluble vitamin. But what about pre-diabetes? We've known that diabetes occurs and it's a dangerous syndrome. But in 2021, 3 years ago, Endocrine Society of India and the South Asian Federation of Endocrine Societies, under the leadership of Professor Rakesh Sahai from Hyderabad, for the first time celebrated World Pre-Diabetes Day. And that is what we are celebrating today. Let's, in the spirit of interdependence, in the spirit of learning from each other, let's first go to Dr. Saptarshi Bhattacharya. Sir, vitamin D and pre-diabetes, from afar, this reminds me of the, in Haryana, we have these Bengali clinics or we have the Fauji clinics where the label says we treat asthma and piles. I've still not been able to figure out what is the link between asthma and piles. But every Bengali doctor, every Fauji doctor in the interior of Haryana treats both these diseases. So maybe the epidemiology is similar, both are common. Treatment is simple. You give steroids for both. That is what happens in parts of our country. But vitamin D and pre-diabetes, how do we get this together, sir?
So thank you, Dr. Kalra, for the nice introduction and setting the stage for this discussion on apparently two different areas of medicine, vitamin D deficiency and pre-diabetes. Also, it's a pleasure to share the platform with Dr. Jothydev, who is renowned for his technological acumen, and we'll see that how his technology can be used to connect these two conditions. And so if we can have a short presentation, may I ask the uh, may talk team to please share the presentation on vitamin D and pre-diabetes. Yeah, so these are two conditions, and apparently one thing is very common about it, that both these conditions are very prevalent, widely prevalent. And also, in many of these people who have vitamin D deficiency or pre-diabetes, the condition remains silent. So we don't get to know that somebody has vitamin D deficiency unless somebody gets tested. And we also don't get to know that somebody has pre-diabetes, uh, so unless a specific testing for plasma glucose screening, or a test called HbA1c, which is the last 3 months average blood glucose test that is done. So having said that, so when we sit in our clinics, we have started getting routine health packages, and thankfully many of these packages do have vitamin D as one of the tests. What we see is that most probably in 80 or 90% of cases, if somebody is already not on vitamin D supplement, either through a tablet or through injection or some fortified oil or some multivitamins, we found more or less the levels to be invariably low. And this is so common that if you go into the world literature, it's not that India is low, so it's different. It's low in US, it's low in Europe, it's low in Africa, and people might argue that India is a country which is rich in sunlight. So, and apparently vitamin D gets synthesized from the sunlight. So why, despite so much of sunlight, despite being a tropical country, our vitamin D levels are low? So this leads us to some important questions. Some even challenge the fact that whatever we are labeling as low is actually not low. So we might need require a different threshold for diagnosing vitamin D deficiency. But what we have seen is that if the vitamin D tends to go below 20 nanogram per ml, or even sometimes 30 nanogram per ml, so there are definitive changes which takes place in our system, like our calcium starts absorption from the gut, it starts going down. And as a compensation, there is a hormone called parathyroid hormone, which is a compensatory hormone which maintains calcium and phosphate balance in our body. So that starts going up. So these changes starts taking somewhere between 20 to 30 nanogram per ml. So most of the authorities world over will label something like a 29 nanogram per ml as vitamin D insufficiency, and rather vitamin D deficiency, and 30 nanogram per ml as insufficiency. So this has a scientific background. So there are definitive physiological changes which takes place in our body that makes us prone to not only calcium and mineral related disorders and osteoporosis and increased fracture tendency, but also there is a tendency that vitamin D deficiency has been connected to multiple other conditions, like development of diabetes, development of cancer, development of infectious disorder, even though in many of the cases those connections are not totally proven. So when we hypothesize that this disorder is causing this deficiency is causing a particular problem, what we try to do is that we give we find a group who are both deficient in the condition. One group receives the vitamin D supplementation, the other group does not receive the vitamin D supplementation, and we follow these people up later on, and we try to understand whether there is a difference in the outcome in the two groups. So that is what we call as a randomized control trial. And if one group is having a particular, if vitamin D is protecting the group from a particular condition, so we will try to establish that giving vitamin D will prevent a particular condition. So we have definitive proof for bone mineral homeostasis or fracture rates or osteoporosis or muscle strength. There are some other associations which are mostly association like cardiovascular disorder or development of diabetes or development of autoimmune disorders, development of neurological disorders, though those are do not have very strong connection to vitamin D deficiency, but there is still a lot of research going on this aspect. And we have actually understood that pre-diabetes happens to be one of those unique conditions which you can actually prevent by giving vitamin D. It can prevent the progression of to diabetes if you are having pre-diabetes, getting vitamin D levels in the right level. So this is where your vitamin D level should be. So some authorities feel that even a 20 nanogram per ml is enough. Others feel that okay, 20 or 30 is enough to prevent musculoskeletal disorder, but for to uh, having a more comprehensive beneficial effect from vitamin D, the levels might be slightly higher. But again, that is an area which is slightly still not very clear to us, being researched as we have already discussed, but not still not we are not very sure. So in most of our cases, what we try to do, even though the some of the international guidelines will tell that 800 or 600 unit of vitamin D is okay, but what we see is that in Indian condition, so because of we even if we are exposed to sunlight, we are mostly clothed, we are not going for a bath on a regular basis. There is also a lot of pollution which prevents the ultraviolet B light, the component of the sunlight that causes vitamin D synthesis. So that also gets filtered out, and we have a darker skin. So all these factors put together, there we have a lower level of vitamin D, and most of us can actually safely take in. So we have this 60,000 unit tablets or sachets or liquids or capsules. So any 60,000 formulation, if you, for an adult, if you are taking on a monthly basis, that will provide around 2000 IU of vitamin D. So that is usually enough, and you can, unless you have a actually bone disorder like osteoporosis or some you are having a chronic kidney problem or a liver problem that really makes you susceptible to the ill effects of vitamin D deficiency. For a normal person who comes to your OPD on a routine checkup, you can just prescribe one vitamin D sachet or capsule 60,000 every month. And even the recent guidelines from Endocrine Society of USA, it suggests that you don't even need to check vitamin D levels in most children and adults, and can actually just give a small dose on a regular basis without any monitoring. So this is our body's daily requirement, at least in the Indian context. For the Caucasians, it's slightly lower, but we can safely take this. And if you are taking this, you are actually protected from rickets, osteomalacia, osteoporosis, muscle functioning falls in elderly. So these roles are quite proven. But what we also are trying getting to know is that vitamin D and metabolic disorders also have a very strong connection. The connection is actually sometimes bidirectional. So maybe obesity will cause the people who are obese, who have excess fat, they have a higher tendency for vitamin D deficiency, and on conversely, vitamin D deficiency itself can cause obesity. The same bidirectional link actually also applies for diabetes and vitamin D deficiency. So this, since it's like it's a positive reinforcement mechanism. On the other hand, if it's deficient, it will be a negative reinforcement. So a negative effect, which just goes on into a vicious cycle. So it was actually studied whether vitamin D, giving vitamin D to persons with pre-diabetes can make a difference. So if we now come to pre-diabetes, Dr. Kalra already told you. So diabetes, it's a progressive disorder. So you are into a stage of normoglycemia to start with, when your glucose values in the blood are absolutely normal. Then you go into a borderline stage when the fasting plasma glucose is somewhere between 100 to 120, 100 to 125, or the HbA1c value is between 5.7 to 6.4. So in that, or you do a glucose tolerance test and the values are intermediate between 140 to 199. So this is the area where we label somebody as pre-diabetes. Till now we have uh, tried to uh, take this as a benign situation, but what is quite alarming to know is that when somebody is getting diagnosed with diabetes to start with, almost 70 to 80% of the insulin secretory capacity of the pancreas is already gone. So when you are detecting somebody with pre-diabetes, the person is going through that transition of 30, 40, 50%. So that is most probably the time where you need to intervene actually, where you can prevent diabetes or remit diabetes. So if somebody is having over diabetes, the chance of going into remission, it does with extraordinary effort, but the chance definitely goes down. So there is pre-diabetes is a condition which is common, and we have physiological link, we have the molecular pathways to understand that the vitamin D deficiency can impair insulin secretion from the pancreas, as well as it can increase insulin resistance in in the liver, in the skeletal muscles. So in diabetes, obviously there are many more mechanisms, but the primary mechanism remains a combination of insulin deficiency and insulin resistance. So that gets reinforced. And in a very recent guideline in 2024, so this was as Dr. Kalra told, that there is a question of interdependence. So this is so people have tried to connect vitamin D with cancer. They have tried to connect vitamin D with multiple sclerosis. They have tried to connect vitamin D with other autoimmune disorders. But again, if we have done systematic studies, we could not demonstrate that giving vitamin D is actually preventing that disease. But this is one condition. We have studies coming up, which have we have systematic collection of studies called meta-analysis, which have been done, and it clearly shows that there is a protective effect of vitamin D from in the terms of from progression from pre-diabetes to diabetes. The risk goes down significantly, and this is one area where we need to be very, very careful, that if somebody is getting diagnosed with pre-diabetes, again we try to ignore those situations. This is not an area where we should be ignoring. We should be more careful. Vitamin E deficiency, very common. We usually give a weekly course, 8 weekly course, then the person stops it, again checks it after 6 months, again the vitamin D levels are low, again we give a 8 weekly course, again it stops. So rather than doing that, it's better to give a maintenance dose of one tablet in a month. It's not going to add too much to the pill burden. And actually, if pre-diabetes, so diabetes prevalence is like 10-15%, the pre-diabetes prevalence will be actually double that of that, and it's hidden. So unless you get tested, you won't get to know. But if you are intervening at that point of time, you will actually see that vitamin D can protect. So just to give an example or analogy, metformin, if you are giving to a person that 70 out of 1,000 participants in a diabetes prevention program in the USA, they were protected from diabetes. So even if you are giving vitamin D, so you might not reach the numbers of metformin, which is purely a anti-hyperglycemic medication. But vitamin D is something which is just a vitamin D supplement, and a 3-year risk reduction of almost 33 per thousand participants, in one meta-analysis, another systematic review, it was 24 per thousand. Almost half the protection that was offered by metformin was actually offered from vitamin D and pre-diabetes. So again, this is a relatively new area where we are going into. We this is like the one of the first associations of vitamin D, which was shown that it can be prevented by giving vitamin D supplementation. Obviously, you are protecting from musculoskeletal complications, but if you are looking into metabolic complication, this was most probably only want to go into the level of a recommendation that you need to give vitamin D to prevent progression from pre-diabetes to diabetes. But there are multiple researches which are still going on, so we don't know it's going to be cost effective or not. But again, this is one area which we can very safely do it. So we don't need to have take any extra risk. We don't need to do any extra investigation. Just one tablet of vitamin D, and it will make so much of more add so much of more meaning to the health issues you are having. So it will silently protect from so many other complications, including musculoskeletal complication, and also probably from progression of pre-diabetes to diabetes. Thank you for being part of this program on this very important day, pre-diabetes day. We all celebrate World Diabetes Day, but just after 3 months from now is World Diabetes Day. But I think if you really want to prevent diabetes, really want to cure diabetes, really want to protect yourself from diabetes, this is the time you need to be more careful and should take pre-diabetes much, much more seriously. Over to you, Dr. Kalra.
Thank you so much, Dr. Saptarshi. And the take home message, we should take pre-diabetes more seriously. That is very well taken. We must remember that in medicine, we have these, levels. We have these thresholds for diagnosis. We also have thresholds for intervention. But these thresholds are meant for convenience. Let's look at the world in general. You divide things into living things and non-living things. But there will be some things in the middle, which are partly live, partly non-live. We can divide living beings into animals and plants, but then there will be some kind of organisms which are part plant and part animal. So the definitions are based upon convenience, they are man-made definitions. Similarly, the definition of diabetes, the threshold for pre-diabetes, and the label for euglycemia, these are man-made. Of course, we use very good quality research to see the long-term prevalence of complications, especially microvascular complications, before choosing these cutoffs. But the point we want to make here is that it's not necessarily binary. As glucose levels go up, risk will go up. Diabetes will occur faster, complications of diabetes will occur faster. And if you can prevent diabetes, prevent pre-diabetes, prevent the complications of diabetes, that is more than welcome. And if you can prevent it with a nutritional intervention, then that is wonderful, nothing better than that. But let's involve Dr. Jothydev. So, Dr. Jothydev, we were talking of those clinics, where they speak of treatment for asthma and piles. Do we have the same thing in Kerala as well?
Yeah, all over India they'll be there.
So,
All over India.
yeah, I thought, and then I realized that what they have in common, these two diseases, is that both are endemic. Asthma and piles, both are endemic to our country. So let's speak about vitamin D and about pre-diabetes. Are these epidemics or are they endemic to our country? Sir, what is your take on this?
But before answering your question, let me tell you, like vitamin D, you are also very unique. Our Dr. Sanjay Kalra is very unique, and that is one of the reasons why I am participating in this program. So he is one of the world-renowned leaders from India. So I think you will agree with me, Dr. Saptarshi. Uh, he is an academic leader, and he is into different organizations. He is an excellent orator. And I know that you have also done a lot of research on vitamin D. And as you said, in modern medicine, the newer medications, the newer research, the newer publications, the evidences are helping us reach our goals. From an average life expectancy of around 24 or 30 years, 200 years ago, we have reached up to 75 to 80 years now. And the vitamin D will also, I believe, have a role. And of course, we were joking about asthma and the piles, but going through the quacks in India, they're treating almost every disease. But looking at the data emerging from vitamin D, maybe this medicine is having a role in many illnesses that we are not aware of. And a year ago, I was having a discussion with a neurologist at the Cleveland Clinic in the United States. And he was telling me that they are using high doses of vitamin D for treating pain. And this is one of the very common prescriptions in the United States in rheumatology as well as in neurology for treating the pain. And I know that all the three of us and many other doctors are using the same vitamin D for managing the neuropathic pain in diabetes. Excellent results. And the second reason why I'm here is, other than Dr. Sanjay Kalra, I myself is a strong believer of vitamin D. And we have been using vitamin D in our practice for I think, more than 14 years now. And giving excellent results. And we have also published some of our uh, evidences from our centers. So can I share the slides, Dr. Sanjay Kalraji?
Yeah, sure.
Yeah, I will. So let me see whether I can share the uh, screen. Dr. Saptarshi was also making a comment on technologies in diabetes. So let me see.
Okay, so communication and technology.
Yeah, communication technology. So sharing the screen and then okay, fine. So this is a very brief presentation where I have included some of the older papers and the newer emerging evidence, and some of these have already been discussed by Dr. Saptarshi, but I will make sure that there is no repetition. And of course, thanks to all of you, we are remembering diabetes, and today is World Pre-Diabetes Day with a scope of prevention from progressing to type 2 diabetes. And this is again remembering Dr. Sanjay Kalra. A couple of years ago, he requested me to write a chapter on the pathophysiological defects in type 2 diabetes. And this is for a diabetes textbook published by Springer, a very popular textbook. And I think the second edition has also been published now. And when we were discussing about the 13 treacherous reasons for type 2 diabetes, as discussed with Dr. Sanjay, something which is staring on you, there is a sun staring on you, and that is vitamin D deficiency. Now, recognized as one of the pivotal components for the pathogenesis of type 2 diabetes, along with the usual ones. And this is one of our earlier papers, optimizing vitamin D levels and improving glucose control. And this was presented at the ACE meeting in the United States. And this is what we have observed. Of course, this is long ago. This is in what year? We did this study in 2012. A total of 1485 subjects who visited our clinic and who could afford a vitamin D evaluation. And to put it simple, only 18% of the patients with diabetes had normal vitamin D levels, defined as above 30. And below 20 is categorized as deficient. And this was a time when we probably started supplementing. And many patients, you can see that the average vitamin D levels were between below 3 nanogram per ml and 63 nanogram per ml. So when we are assessing vitamin D levels in 10 people, on an average, 2 of them will have normal or even vitamin D levels up to 80 or even 90 without any supplement. So now we are increasingly recognizing the extraskeletal effects of vitamin D. It is beyond rickets and osteomalacia. And the D receptors are now identified in multiple organs, including those of our interest in the pancreatic beta cells, in the skeletal muscle, in the adipose tissue and the liver. And the animal studies have shown that the D deficiency could be associated with impaired glucose-mediated insulin secretion, insulin resistance, and so on. But probably the doctors are confused because of the mixed results from the clinical trials and even from the randomized control trials. And vitamin D is still a topic of debate. And these are the probable mechanisms by modulating the immune system, reducing the inflammatory markers, the cytokines. Vitamin D helps to mitigate the ongoing low-grade inflammation, and that can probably increase insulin sensitivity. And when you are supplementing vitamin D, there could be even 10 times more efficient absorption of the calcium. And the disruption of the calcium metabolism when there is vitamin D deficiency can also impair glucose metabolism and insulin action. So this is something which we are aware of currently. So let me go through some of the earlier observations. This is more than 10 years ago. This is in 2013, a meta-analysis. And this is to probably look at the evidence on incident diabetes and vitamin D levels. So 38% higher chances of developing new onset diabetes. And this is highest vitamin D levels versus the lowest categories. And this is one such study which probably gave a signal of vitamin D deficiency and the occurrence of diabetes. And this is probably demonstrating the heterogeneity among the studies. So if you look at the multiple studies listed here, the total numbers were very small long ago in almost all of these studies, and the primary outcome in almost all primary and even the secondary outcome was not vitamin D and diabetes. It was a women's health initiative. We can go through diabetes prevention program where vitamin D was also given as a supplement. And some of these studies were of very short duration, 2 months, 1 year, 16 weeks, probably insufficient to make conclusions on prevention of diabetes. So these are all the limitations, not primarily designed for glycemic outcomes, and they were underpowered for the same. And you can see that most of these studies have used very low quantities of vitamin D, 700 units per day, 400 units per day, and they were probably insufficient. And when we are providing vitamin D in studies which are not primarily meant for that, the adherence will also be relatively less. And that is also another possibility. And there were improvements in the fasting glucose, hemoglobin A1C, statistically significant, but the numbers were minimal. The mean difference of 0.10, but still in pre-diabetes and its progression to type 2 diabetes, even those minimal improvements will also have a substantial benefit. So apart from these limitations, the confounding factors, the healthy people who are exercising, getting exposed to sunlight may have better vitamin D levels, and adiposity is definitely inversely correlated with 25-hydroxy levels. And in our studies from our center also, we observed that obese people, they have relatively low vitamin D levels in Kerala. And this is also well known. And this is somewhat newer ones in 2018, a Chinese study, and this is 4 years. So fairly long duration, suggesting that low vitamin D levels might have contributed to the occurrence of pre-diabetes and diabetes. Meta-analysis of 29 published studies demonstrating improvements in fasting A1C and also fasting insulin levels. And long-term vitamin D supplementation for years will have additional benefits in HOMA IR and maybe HOMA beta as well. And vitamin D and insulin sensitivity, and this is published in the official journal of International Diabetes Federation, DRCP, double-blind placebo-controlled trial, 163 patients. And these are people with documented vitamin D deficiency where subjects are randomized to either vitamin D3 or to placebo. So those who are given vitamin D, there was a substantial improvement up to 36 nanogram versus only 16 nanograms per ml in the placebo group. And the vitamin D group showed a significantly lower HOMA IR score, so the insulin sensitivity has improved and reduced risk of progression towards diabetes. So signals that vitamin D is having a role. And more than 1000 IU per day, vitamin D supplementation can reduce incidence of type 2 diabetes in patients with pre-diabetes compared to placebo. More or less a new one, and this is in August 2020 in the Journal of Clinical Endocrinology and ACM. So it's appearing in popular high-indexed journals, robust evidence gradually emerging, benefits of insulin secretion. And this is a study in overweight obese individuals. And these are the people at high risk of developing type 2 diabetes. And these participants, they received 4,000 IU vitamin D3 or placebo for 2 years. So that probably did not improve. They measured the disposition index, but it did not improve the beta cell function in this study. But there are studies which demonstrated improvement in the beta cell function as well. But when you start with a relatively low vitamin D, then there were substantial benefits. And the vitamin D supplementation increases serum levels from 27.9 to 54.9. So you have the evidence, and low levels of vitamin D definitely is inversely associated with type 2 diabetes occurrence. And this is thought to support pancreatic beta cell function, improve the insulin sensitivity. And the risk of occurrence of pre-diabetes increases with vitamin D deficiency. And definitely there is a dose-response relationship. That is where probably we are debating the threshold levels. And the threshold levels of vitamin D could be different in normal people versus those with other chronic illnesses. So that is where we need to have a different guidelines for those who are in quotes normal versus those who are having symptoms of vitamin D deficiency versus those who are having multiple other chronic illnesses, including diabetes or obesity. a meta-analysis of 8 randomized control trials. And this is in Diabetes Care, the official journal of the American Diabetes Association, a very recent one in 2020, including 4,896 participants. And this is a meta-analysis where in pre-diabetes, these supplementation reduce the risk of occurrence of type 2 diabetes by 11%. So this is very, very impressive data. And further reduction by reversing pre-diabetes to normal glucose tolerance state by 48%. So this is something which can be considered very robust. And the benefit of prevention type 2 diabetes appears to. So this is another limitation for this study. It is confined in non-obese subjects, and that is probably understandable because in obese subjects, apart from vitamin D, there are multiple other risk factors for the development of diabetes. So if you are not controlling the vitamin D supplementation alone, probably will not help them prevent diabetes in obesity. And this is the new NEJM publication, the D2D study, which is probably discussed everywhere, and unfortunately not powered for preventing the pre-diabetes to diabetes for smaller numbers. So it was powered for 25% reduction in the progression of pre-diabetes to diabetes, whereas if it was 10 or 15% smaller numbers, it probably could have given positive results. And many of those who were in this study, they were already on vitamin D supplements. So currently, the Endocrine Society, this has been elaborated by Dr. Saptarshi from the United States, the Endocrine Society. In pre-diabetes, empiric vitamin D supplementation. And I have I have concerns, and I will get the clarification from both of you on whether we can go ahead with vitamin D supplementation without lab investigations. And these are the recommendations of vitamin D published in JAPI. In adults and elderly, daily requirement 1,500 to 2,000 units per day. And this is again JAPI, Horlick et al. Against Balasubramanian. I had the fortune of listening to Horlick. I think he spent his entire life researching and publishing on vitamin D. And I believe he has discovered more than 100 illnesses where he is using vitamin D. And the similar recommendations from Horlick and Balasubramanian in the ages above 18 years, 1,500 to 2,000 units per day. I won't be discussing this algorithm, and this is published by Dr. Sanjay Kalra, and I will request him to discuss further on this algorithm. Before that, let me share my experience, and this is one of our patients. We routinely assess vitamin D, perhaps twice a year, or if the patient is asking us. Otherwise, we do the vitamin D evaluation once in a year. And this is in 2013, 2015, when the D levels are diminishing. So in our practice, when we are giving daily doses of vitamin D, somehow most of the patients are not achieving more than 40 or 50 levels. Whereas when we are providing them with 60,000 units once in every 10 days, then I am able to maintain the so-called acceptable levels or optimal or normal levels above 30 or above 40. If they are having a pain, then preferably, as per the discussions I mentioned earlier, I used to maintain it above 60 or even 70. So the moment you stop supplementing, the vitamin D levels drops. And this is again another mistake the doctors usually commit. You are not supposed to give vitamin D only for a few weeks or few months. It has to be continued. And once in a while, I think estimating vitamin D levels also makes sense. So I stop here. And thank you very much for giving me this opportunity.
Thank you so much, sir. Great discussion by both the speakers. And we now have a fair idea of why pre-diabetes is important, why vitamin D adequacy is important, and how they are linked together, vitamin D deficiency and pre-diabetes. When we speak of prevention of disease, prevention of metabolic disease, many times our patients say yes, thank you for doing that, and other times they say, why are you bothered, when I get the disease, then I will come to it, then I will think about it. Right now
Why
I'm
should I be unnecessarily on a drug? That is what patients ask. Why should I be unnecessarily on a drug, even if it is a cheaper drug?
So how do we sort of manage this, Dr. Rishi? In your OPD, somebody comes and says, "I don't like taking medicines." What can we do to motivate the patient to take vitamin D to manage pre-diabetes?
So I think that this is a very, very common situation. But the most important thing which we need to make somebody understand is that there's a difference between a medicine and a vitamin. So medicine, though most medicines are studied and they're safe and they're there because to help you, not to harm you. So there can be some aberrant side effects occasionally, but somebody might still argue that why should I take in a unnecessary chemical or something like that. But vitamin D is not a chemical which is like a which behaves like a medicine or so. It's just a vitamin D supplement which is normally there in our body. So our body is supposed to produce it from sunlight. So for some reasons, maybe we had less pollution earlier, we had more sun exposure, we were not confined to air conditioned buses and air conditioned cars and offices. We used to take a walk to People used to take a walk to their offices or went by bus, went by trams, went by trains. So there are lots of more sun exposure at that time. Now you are coming out of your house, entering the car, then you are just in front of coming down in front of the office. So there is hardly any sun exposure. And on top of that, in cities like Delhi, pollution does there are times studies also suggest that if the pollution level goes up, the PM 2.5 particles, they prevent the ultraviolet B light from coming in. So this is something which should naturally get synthesized in our body. So till now our body might have been doing so, but for whatever reasons, whatever changes we are going through in our globally and in our day-to-day life, so with the body is not able to produce the right amount it should be producing. So we are just supplementing the natural substance which should be there in the body in a tablet form or a capsule form. So first of all, if somebody is telling that okay, if you why am I taking a why do I have to take a medicine on a monthly basis or a weekly basis? So first of all, it's not a medicine, it's a vitamin D which should be naturally there in your body. And uh, the other thing, sometimes even if somebody might tell, so there are even indications, we're discussing pre-diabetes, that metformin can prevent pre-diabetes also. There are studies to show that. But people might still argue that we don't want to do it. The other way to tell is that, so if one simple medication can prevent 10 more complications in future, and 10 more medication taking stop you from taking 10 more medications, so I think it's better to stay fit and not count the number of medicines and take just one tablet. And especially if this medicines like be it vitamin D, obviously the lifestyle change is the best thing to do, but not many people are doing so. Vitamin D, I don't consider it as a medicine. So my son is in class 4, so I sometimes do give him. So occasionally I also give him a vitamin D tablet. I don't think why am I giving my son a chemical or a medicine? So this is, I also personally take it. Maybe you most of the doctors also personally take one in a pill of vitamin D. So this is not something which should be a concern for any of us, that taking vitamin D is taking a chemical or a drug and it will have some side effects.
So first of all, tell your patients it's physiological, and secondly, you can do self-disclosure also that I take it and my family members take it. Dr. Jothydev, your comments when patients, let us say, uh, they're a bit apprehensive or too inquisitive or too maybe argumentative about vitamin D. Any best practices from your opinion?
Because I do the same, Dr. Sanjay. I will show my phone. In my phone, there is an alarm every 10 days, and the alarm says vitamin D. And I tell them that this alarm is meant for my vitamin D intake, and I take it every 10 days. So they are convinced.
So this
But
is where technology comes in. I told you.
Technology. So self-declaration and technological self-declaration. That is
so
nice.
yeah, yeah. Very good, very good.
Yeah.
And this is not that expensive also, so they are okay with that. But when we are giving it daily, then as Dr. Saptarshi said, then it is a burden for them. Because a daily one more tablet is a burden for, but once in a while it is fine, and they most of them will remember it. And once it is like insulin, because the moment they start taking insulin, and if there is no hyperglycemia, there is a sudden improvement in the quality of life. They feel better. So likewise, when they take vitamin D, then there is a feeling of well-being. And this is appreciated when they stop a dose. After 10, 15 days, they realize something is happening. But I have two concerns, and with your permission, let me ask Dr. Sanjay two questions which I had. Uh, because in the Endocrine Society guidelines, it is recommended that give daily doses rather than intermittent doses. And I don't know whether this is based on any findings or a study, but I have seen a couple of my patients, one or two patients, especially in the pediatric age group, where they have made a very gross error. I think that is a very serious error, taking 60,000 daily. But somehow we could make it within a month or so, and there was no toxicity. I know that there are published papers on vitamin D toxicity with daily 60 given for 3 months or more, 4 months together. So that is a grave mistake, and that is a grave concern when we are recommending on a daily basis. So when we are recommending 60,000, I think once in 7 days or 10 days, we should be very careful. And my second question is, do you agree with the Endocrine Society recommendations on empirical therapy without any lab investigations? Where in the Indian population, out of every 10, we have seen two people having more than 80 or 90 nanogram per ml. And still, when we are supplementing, are there any chances of high vitamin D levels? So, thank you very much.
Let me take these one by one and then we ask Dr. Rishi. There are three questions which have been put to us. First of all, should we treat? Should we have a biochemical threshold for intervention? Should we have a biochemical target? Or should we treat empirically without any biochemical numbers, just with quality of life and sense of well-being? That's the first question. The second question is, if we decide to treat, should it be daily or weekly or fortnightly or whatever? And the third is, what is our target? We need an endpoint when we are treating. How long and why, for example? What happens if vitamin D becomes low or if it becomes too high? So let us do this one by one. Empirical therapy, the way we eat food, there is no single right or wrong for how much pepper I can take or how much salt I can take. The same food will be cooked in different ways in different households. As long as you are within a particular range, things are fine. For some hormones, like for insulin, for example, there is a very narrow therapeutic index. So the chances of making mistakes are very high. In a person with type 1 diabetes, instead of 4 units, I give 5 units, hypo might occur. For other hormones, let us look at TSH, normal range from 0.4 to 5.0. So huge chance of variation. Similarly, for vitamin D, we have a very wide window of therapeutic effect. That is one reason. So you can prescribe empirically. We have to know about the risk-reward ratio. The reward that you get when you give adequate vitamin D is immense, not only for musculoskeletal, but also for metabolic, mitogenic care, for health. So therefore, we must take advantage of this reward. What is the risk of vitamin D toxicity? Usually it will be seen only with parenteral vitamin D. And that also, when our colleagues from some of the other surgical specialties, they give 6 lakh units of vitamin D every week or something in a misguided effort for anabolism. So as long as you are not doing that, the risk reward ratio is very low, or the reward risk ratio is very high with vitamin D. So therefore, we would support empirical therapy. Another reason for supporting empirical therapy is that the cost of the medication is minimal, the cost of the test is maximal. So it doesn't make sense. If at all you are worried about the risk of hypercalcemia, the simplest and the cheapest test to do is a urine routine for calcium crystals. So the old-fashioned style, if there is calcium crystalluria, then you do other tests. But if there is no calcium crystalluria, go ahead and use. Here, a question will come, what about kidney stones? If I give vitamin D to everyone, then what will happen to kidney stones? Everybody will develop stone. Actually, the opposite is true. In India, we have a renal stone belt which goes from Jammu to Jamnagar, that is from Jammu and Kashmir up till Gujarat, and then from Amritsar, which is Punjab, to Agra, that is UP. So this is the northwestern part of the country. The stones are usually phytate. If you give adequate vitamin D and you get adequate calcium, actually the phytate concentration goes down and the incidence of renal stones goes down. So that we should be aware of. If you want to blame diet, blame phytates. Phytates will come in chapati. Then everybody should stop eating chapati. So our first topic was risk-reward ratio. The risk-reward ratio is such that you can actually use empirical therapy. If you have someone with the symptomatic vitamin D deficiency, no harm in treating for 3 months without investigation. After 3 months, if you think things are not fine, then you investigate. But if on day one your clinical suspicion is primary hyperparathyroidism, then certainly we should investigate. So that is the clinical thing. Why are you doing? If your clinical suspicion is tumor-induced osteomalacia, then we must investigate. But that is based on good clinical sense. The second part that Dr. Jothydev alluded to was daily, weekly, fortnightly. So daily is also okay, but we should know that in the US, the drug that is usually used is ergocalciferol, which is less potent. The drug that we use is cholecalciferol, which is more potent, which is better. So therefore, we have evolved in a different way. Secondly, certainly it is easier to remember every week or every 10 days. Like Dr. Jyothidev said, you put an alarm. And our Indian culture is such that we are tuned to these weekly and fortnightly cycles of life. So I might tell my patient every Jummah or every Jumerat, that is every Friday or every Thursday night, why don't you take the tablet? Another person may say, I will not remember Friday, but I am very sure I can remember Monday or Tuesday. So this is the month of Savan across India, and many people are keeping Monday fasts during the Savan month. So they might want to remember Monday. Fortnight is wonderful because I tell my patients after having given them vitamin D for 3 months, now why don't you let's learn the lunar calendar? And everyone will say, yeah, that's there in my religion. It is there. So do you remember the lunar calendar? So let's take one vitamin D every full moon day and one vitamin D every new moon day. And patients come back very happy because they say, yeah, now I remember, it makes things easier for me. So that was the second part. In general, I would encourage weekly instead of daily, but both things are fine. It depends upon your patient. The third is target. Now, when you read classic endocrinology teaches you that how do you define diabetes or pre-diabetes based upon the risk of long-term complications? How do you define normal vitamin D based upon the parathyroid concentrations? They chose the normal vitamin D in such a way because below that, serum PTH begins to go up. Above that, serum PTH remains normal. If serum PTH goes up continuously, it is a catabolic hormone. So if my vitamin D is low continuously, my serum PTH will become high continuously 24 hours a day. That is catabolic. My bones will become catabolic. This is true for musculoskeletal parts of vitamin D. But when this definition was made, we were not aware of the metabolic or mitogenic, anti-mitogenic, or anti-miasmic. Miasma means infection. We were not aware of the fact that vitamin D improves metabolic health, that it can act as an anti-mitogenic, that it can be anti-miasmatic. It helps fight COVID-19 also. It will reduce the risk of developing COVID-19. It will reduce the risk of succumbing to COVID-19. So we were not aware of this. The PTH based definition is a unifocal kind of a definition based only on musculoskeletal health, not even musculoskeletal, just on skeletal health. And if we say that vitamin D has multiple effect, that is like quantum physics, we should find a new definition. That maybe work for Dr. Saptarshi's DNB candidates now over the next few years. So let us just summarize what we have said. Empirical therapy, I think, should be uh, propagated. Yeah, just 1 second. The way ESI, the Endocrine Society of USA said, daily, weekly, fortnightly, as per the patient's requirement and whatever the patient will remember. And target, again, we have the numbers, but rather than that, we should target well-being and good health. If you want to do any test, urine calcium should suffice. Urine calcium crystals. Dr. Rishi, please.
So, specifically, if we go into the US Endo guidelines published in JCM in 2024, so the empirical recommendation is for those for children below 18 years and for adults above 50 years. So, from 18 to 15 years, they have not recommended, and the dose they have recommended is 600 IU per day. So that is actually, so many of our patients are on tablets, calcium tablet, which are 500 unit per day, and even though they will come back with they are compliant, we check their vitamin D levels, it's still low. So whatever vitamin D levels they're asking to take on an empiric basis without testing, is a very, very low level of vitamin D, at least in the Indian context. Regarding the weekly versus daily dose versus higher dose, so there were multiple studies which were done, and the meta-analysis showed that if you are giving higher dose, more specifically if somebody is getting injectable or bulk doses of oral, maybe 6 lakhs unit at a time, so very high doses of vitamin D at one shot also has a bone suppressive effect. So there was a 0.5% increased risk of fracture in the meta-analysis which was analyzed, which showed that that was the only reason they had put it. But when if you go through the guidelines and the discussion, they also say that this is something where we need to assess cost effectiveness, and also we need to balance the this minor trivial benefit which is the basis of recommendation versus the convenience and the inconvenience cost to the patient because of a daily additional tablet. So still this is the first time somebody has said that daily might be better on the basis of fracture data, but the risk was very the difference was very small, and maybe still an evolving area unless we have more studies which is specifically focusing on, and they have put all types of bulk vitamin D together. If you are studying maybe a 60,000 we monthly versus a 2,000 daily, I'm not sure we'll get that difference in the fracture which was the basis of this recommendation.
Well said. We should also be aware of practical and pragmatic issues. So whatever the patient, someone may say, I remember daily dose better. Other person will say, I remember weekly better. Let it be. But usually weekly, if we start, that's fine. Another thing is, apart from the fact that they've recommended in children and in adults, elderly or middle-aged adults, it is also recommended in people with metabolic disease, like pre-diabetes is mentioned specifically. So pre-diabetes is a high-risk metabolic syndrome or condition, and vitamin D is recommended there.
And
It's a
pregnancy
major
also, that is one situation where
pregnancy.
we should be giving. So it has multiple benefits, even maybe epigenetic benefits for the children in the long run.
And a lot of discussion now about using vitamin D, daily vitamin D in first trimester as well, because first trimester vitamin D helps prevent diseases like pregnancy-induced hypertension, preeclampsia, the pregnancy loss in later pregnancy. So these are also upcoming fields for research. Of course, we need to learn more and more, but as we fight the pre-diabetes endemic now, we need all hands on board. And before we talk of drugs and before we talk of immunotherapy, we should at least do nutritional optimization. And in nutritional optimization, it's not enough just to talk about, like in ICMR India, we speak about reducing the carbohydrates to 50%, increasing the fats to 25, and the proteins to 20%. These are ICMR India based guidelines. So that comes later, that is macronutrient. We should also have micronutrient optimization. And in micronutrient, vitamins and minerals are important. So calcium and vitamin D are important, and we should not ignore these. One other aspect, if Dr. Jothydev, you could take about it. Now, earlier, maybe we are celebrating our Independence Day now tomorrow. Earlier, we were short of food. There was no food security. Independent India has also gone through famine. Now we are very happy that there is no hunger. But there is something known as hidden hunger. Hidden hunger is vitamin, mineral, electrolyte insufficiency. So just a question, in rich South India, in upper middle class South India, is there still hidden hunger?
Anyway, we are not rich. You people are more richer than us.
No, the question will
Yeah.
come to Dr. Rishi about New Delhi. So we are asking now about South India. But
Yes.
is there hidden hunger? What is the quality of food intake?
Yeah, because you know that when you compare, because we during the COVID period, we always used to say that after COVID, we'll refer to that era as before COVID and after COVID. So when we live in this era after COVID, then ordering the food via the online platforms and getting the fast food, even without going to the restaurants, most of the people are eating out from the house itself. So this hidden hunger, of course, is increasing, and there is a gross deficiency in the nutrient-rich foods, and they are used to fast foods. And when we discuss about lifestyle modifications, because that is the most important. Whenever we discuss about medications, even for vitamin D, I tell my patients that vitamin D is no longer a simple vitamin. It used to be a vitamin earlier, but now it is not a vitamin. It is definitely something which could be even considered as a medicine, but you take it as a vitamin because it doesn't have any side effects. But for optimal action, you have to take it after a meal, preferably with some fat so that the absorption is optimal. Because without giving that instruction, some patients will have it on an empty stomach because they can swallow it and they will take it as an empty stomach, they will chew it, and then the absorption will be very limited. So with vitamin D also we give all those instructions, but as we have seen the studies, in the recent NEDM study also they have seen that in obesity it doesn't have a role. So when we are discussing about pre-diabetes on this very special day, we should be discussing about the nutritional aspects of health as well as the physical activity. Physical activity should be at least 1 hour a day. We should be sleeping for 6 to 8 hours per day, not less than 6 hours and not more than 8 hours per day. So all these are having an equal importance. So just by providing vitamin D to those healthy people or those with a propensity to develop diabetes or pre-diabetes doesn't mean that it is going to help. It should be a multi-pronged approach in preventing diabetes. So when we are commemorating pre-diabetes on August 14, we are giving the message not only on vitamin D, on top of all those lifestyle modifications, diet, exercise, sleep, and multiple other parameters, we should be definitely including vitamin D as well. And this is recommended as a 60,000 a chewable tablet, preferably, or as a capsule, available in multiple forms. And as you said, it is available as cholecalciferol in India, well absorbed and capable of reaching optimal levels. And we should also discussing about nutrient-rich food, both in micro and macronutrients. And most of the so-called tasty food, delicious food, they are not properly a healthy food. And we should be aiming at children in the schools and colleges, and not to forget about the pediatric population where the frequency of use probably will be 60,000 once a month or once in 2 months. Because we see a lot of pediatric population as well. And one more message from my experience, whenever I feel as if somebody is vitamin D deficient, I used to give the same to the family members as well, because it runs in the family. We may be probably treating only one person, one member in the family, but this is a duty of all of us as responsible doctors to provide the advices and instructions on a healthy supplement like vitamin D, which has got a pivotal role in the prevention of multiple metabolic illnesses, to the family members as well, especially the children in the family. So thank you.
Right, well taken, and that reinforces what we said in the beginning about interdependence. So all
Yeah.
these factors, all these interventions are interdependent on each other. You can't have diet alone, you can't have exercise alone, neither can you have pharmacotherapy alone. Everything together is needed. This reminds me, Dr. Saptarshi, of the concept of fusion cuisine. So some people like traditional foods, others like monochromatic or single type of beverage, the same beverage every night. But fusion cuisine and vitamin D and sunlight and pre-diabetes management, this would be another way of explaining to our patients the same way you like different types of foods together, a balanced diet and uh, a variable or diverse kind of diet. Similarly, vitamin D should be part of the diversity of metabolic management. It's past 5 now, and let's just summarize what our speakers have said. Vitamin D deficiency is endemic to the country. Pre-diabetes is endemic to the country. This is what they both have in common. Both are metabolic issues. Vitamin D deficiency is a metabolic disorder, so is pre-diabetes. Both work with each other, and this concept of interdependence or quantum relationship between these, this is what they have explored. It's not just that they spoke to us about the problem, they also spoke to us about the solution. The solution is that you can use vitamin D to improve overall health. Musculoskeletal, of course, is well done, but there is increasing data to show that vitamin D supplementation helps in improving metabolic health as well. In general, for most people across the country, 60,000 units once a week for maybe 12 weeks. And then you can continue with fortnightly, that full moon and new moon kind of concept, or maybe with a monthly concept. It's very safe to use. If you are worried, a urine routine should suffice. in case you feel that your differential diagnosis includes something else, like a parathyroid disease, or maybe a tumor, or maybe a renal tubular acidosis, then of course you will do the investigations, but otherwise it's not required. And the drug is very safe to use. In fact, it's not a drug. We should be calling it part of nutritional optimization. With this, we have Faraz with us backstage. Faraz, could you please show a certificate of appreciation first for Dr. Saptarshi Bhattacharya, please? And then after that, we take their comments. And then Dr. Jothydev Kesavadev, please. Oh, for both. Okay, thank you. So now we have a googly question from the audience for both. And the first question is, thank you, Faraz. Who would like to take the first question?
It depends on the question. You can ask, then we'll decide.
So let me ask both questions together. The first question is, which is your favorite fusion cuisine? That is to both the speakers. And the second question is, some people will say that, I eat fish 3 times a week, so my vitamin D should be fine. So are you aware of any data which says that fish caught in the wild ocean, fish caught in cold oceans, in temperate oceans, has more vitamin D, but the river fish or the farmed fish that we get in our country, which is coming from tropical waters, has relatively less vitamin D? That's the second question. So anyone is allowed to take either or both questions.
So in 1 month from now, it is Onam in Kerala. So have you heard of Onam? That's a big
Yes.
celebration. And in Onam, we have a very special food, and we call it Onam Sadhya. And we have small quantities of rice along with different vegetables. And it is highly delicious, very, very delicious food. And if you haven't tasted this, you have to take Onam Sadhya at least once. And we don't prepare Onam Sadhya all throughout. It is only during the Onam. And it is a vegetarian food, but we usually nowadays mix it with fish. So we will have fish or occasionally chicken along with the Onam Sadhya. And this is supposed to be highly nutritious. And highly nutritious in the sense that it is not a fast food, and it is a balanced diet with probably the India suggested proportion of carb, protein, and around 50 to 55% carb. And we will have this Onam Sadhya, and we'll have multiple other celebrations. And we will run, and we will have multiple races, and exercise is combined with the Onam Sadhya. So this fusion not only for food, but all the other aspects that we have described.
So perfect example of fusion food, and suddenly fusion food, fusion cuisine, and suddenly I am feeling hungry and thirsty to have a trip to Kerala now during Onam. So we can speak about this also to our patients. Vitamin D is the value add for the Onam Sati or for whatever cuisine is being used, and it's a single pill. It's much cheaper than the equivalent that you would have to spend on fish, for example, and it's something that gives you good health as well. So, Dr. Rishi, now one question taken by Dr. Jothydev. Now you have a choice. You answer either both the questions or one of them. You can also choose to phone a friend or refer to someone else.
I'll take a lifeline. So anyway,
Actually, the
so
fish.
anyway, so I think there are studies in Bengal also. So Bengal, Kerala are both fish eating population. So I am originally from Calcutta. The last 20 years I'm in Delhi. So Bengalis have a high prevalence of vitamin D deficiency. So there are national studies. So it didn't taking fish in India, at least it didn't make much of a difference. Most of the studies related to fish are related to like salmon and cold water fishes. And what you need to understand, these fishes have to be large fishes. So if it's a small fish, it won't have that much of oil. It's the fish oil which is the source of vitamin D. So if it's a small fish, a freshwater fish, so it might be more healthy, because in Europe or US it might not be a problem, but in India a problem with large fishes are that they are also getting exposed to a lot of minerals and
Mercury.
chemicals. So you don't recommend large fishes in pregnancy, because that can lead to accumulation of mercury, arsenic, and cadmium. So large fishes from in Western, as per Western data, which are rich in oil, mostly cold water fishes, sea fishes, they are rich in vitamin D. Freshwater fishes, smaller fishes, might not be that rich in vitamin D. And As of now, I am not aware of any studies which have shown that the fish eating community in India are protected against vitamin D deficiency.
No,
So
no, no.
maybe a good point to research if you look into it specifically after analyzing dietary pattern. But we as of now we don't have any data.
I think Saptarshi, the Kerala population is most of them fish eating. It's a huge fish eating population, and vitamin D deficiency, I have seen it is more than 90% prevalent,
Right.
less than 20.
So these
So
are
probably,
things.
yeah.
These are things that we should be aware of, and if we are able to optimize our nutrition, our micronutrition, obviously that will be one major step towards optimizing our oral health. With this, I'd like to thank both our panelists, Dr. Saptarshi Bhattacharya from New Delhi, Dr. Jothydev Kesavadev from Trivandrum. But even more important, I'd like to thank everyone who has logged in today for this interesting discussion. Let's take the opportunity of Independence Day to remind ourselves that our work is independence from ill health, independence from disease and disability. But how will we achieve this? We will achieve this by interdependence between different specialties, different disciplines, and interdependence between all the various therapeutic modalities that we have, including micronutrition, including vitamin D. Thank you, everyone, and Jai Hind.
Thank you.
Jai-
Happy Independence Day.
Happy.